Oh, thank you, ma'am. Our goal with insulin is to make sure that we're helping our patients maintain a normal blood glucose level. We may be having them take it sub-Q. It can be given IV. Or your patient may be placed on an insulin pump. Insulin pumps work really well. They're some of the newer technologies out there. They work really well. You just got to make sure that your patient is capable of taking care of it. Okay. When we're doing teaching with our patients, we want to teach them about site rotation. And again, the abdomen is the preferred site for administration with insulin. It has a more rapid rate of absorption and less chance that you're getting into muscle. It's a more of a stable rate of absorption. But patients can rotate their sites. Dosages and times of administrations really are set to mimic the body's normal insulin release. Okay? So your patient may be taking an AM dose and a PM dose, like before breakfast and then before supper. They may be taking it before every meal and then at bedtime. They may only be on a sliding scale. Patient education is vital. Patients have to know what their dosage is, how to accurately draw that up, how to accurately administer it. Okay. They need to know how to store it. How do you store it? It's usually in the refrigerator, right? Usually in the refrigerator. Now, I have a grid here that I got from another source. This is not from Iggy. Okay, Iggy has a graph in there. So they're along the same lines, but they're not exact, and I know how you guys like exact. So I will hold you to Iggy standards. Okay? They're off just a tad, but, you know, it's on peaks and things like that. But insulin comes in short-acting, a little longer-acting or moderate-acting, and then long-acting insulin. Your short-acting is your Humalog and your regular. These are the ones where you have results, or it starts to work in a very short amount of time, usually less than 15 minutes, 15 to 30, okay? And then it only lasts for about an hour or two. This is what you're giving with your sliding scales, because we want results based on that blood sugar at that point in time. Okay. Your moderate acting ones are your NPH, your Lenti. You'll see these Humulin N or Novulin N. Ultra Lente is your long-acting. I don't think I've ever given Ultra Lente in my entire career. Never have given that. Lantus. Lantus is a once-a-day shot. This is it down here. Glargine. Yes, ma'am. Can. Humulog or Humulin R is another thing that you may see out there. couldn't figure out why my shirt wasn't fitting right today. Now I know. I'm like, what is that? Y'all had me so tore up this morning I didn't even put my clothes on right. Like, what is up with this shirt? No, I was tore up because I could not find my jump drive this morning. So that I thought, oh my Lord, I'm gonna have to do this off the cuffs though. Anywho, okay, we'll fix that today. Okay. All right. You do have insulins out there that are mixed, that come to you pre-mixed, and these are fabulous. Okay, this is your 70-30s, your 50-50s. Okay, a lot of what you're going to see is the 70-30s. Okay, that's what you give a lot of. But it's really 70% of a moderate acting insulin and 30% of a rapid acting one. You need to review your procedure for mixing insulins, drawing up insulins. Which one is first? What does clear mean? Which is that, the short one or the fast one, or the moderate one? It's regular, which is short, or moderate acting, short. So your short acting ones are clear. You draw them up first, and then your cloudy one is usually your MPH. Now Lantus is clear. That's what I'm saying. Lantus is clear. So you need to look at, you got to read your label. But are you ever going to give a drug that you don't read the label? No. If you do, then I'm worried about your career. So, what kind of which kind of insulin do you give IV? Regular. Regular insulin is given IV. That's the kind of insulin you're going to put into your TPN when you need to give that. Any IV push insulin is going to be regular. They have come out with a new Novolog that they tell me can be given IV, but unless you have that specifically ordered, okay, regular is the only thing that you can give IV. You do not want to mix anything with your Lantus or Levemir. And your book does talk about some complications that can happen when you have a patient on insulin. You can always have damage to the tissues, from repeated injections and all that stuff. So that's why we want patients to rotate their sites. Okay, they do need to know that where the best places are, and how to give that accordingly. But it also talks about a dawn phenomenon, like dawn, D-A-W-N. This is where at night you have a release of growth hormone that raises the blood sugar around 6 o'clock in the morning. So what happens is we need to usually give a little more insulin at night, or we need to give it later. So if you're giving them PM insulin, you're giving it around supper time, and they're waking up at 6 o'clock in the morning and their blood sugar is 600 or 400 or whatever, not 6, I'm sorry. It's elevated, then maybe we need to give it a little later. Okay. There's also a Somogi. I'm sure there's a different way of saying that, but go with me. Phenomenon. This is where you have hyperglycemia in the morning because the patient has dropped his blood sugar at night. Okay, so it dropped and the patient became hypoglycemic, and they have a rebound hyperglycemia. So what happens is your patient probably needs a snack at bedtime to prevent that hypoglycemia in the middle of the night. SOMOGYE. Y-I. I'm sorry. SOMOGYI. Phenomenon. Morning hyperglycemia from the body's response to nighttime hypoglycemia. So they may need a snack. You may need to decrease their PM dose. But usually your patient will have a very restless sleep. With this, they complain of a headache. They may have nightmares, that kind of thing. You may need to decrease the PM dose, so that they don't drop so low. Okay. So Iggy's table is on 1431. But these are the ones I want you to be familiar with. She's got a whole lot of them on there. Just be familiar with the regulars, the MPHs, the Lenti, the Lantus, those that we talk about that are on this thing right here, okay? All right. Now, patients who are type 2, we're going to talk to them about their lifestyle modifications. We're going to put them on a diet. We're going to make them start exercising. We're going to have them monitoring their blood sugar. If those changes do not help, or if they are non-compliant, then we want to go ahead and start our patients on some oral anti-diabetic medications. Iggy talks about a whole bunch of different ones. Okay, these are going to be some of your first line ones that we're going to talk about today. The sulfonylureas. Glucotrol is the main one I want you to know here, because Glucotrol XL or extended release is a second generation one. The Dibeta and Micronase, Glinase, those are first generation. So we don't use a whole lot of the first generations much anymore, but we do give boatloads of Glucotrol. What these drugs do are they decrease the liver production of glucose. So it reduces the fasting glucose levels. This is going to be really your first line therapy for type 2 diabetes. We want to decrease the liver's production of glucose. It doesn't affect the insulin secretion. Y'all are going to kill me. Y'all are going to kill me. I can't post this now. It's got an ugly word in it. Ryan said that. My God. Go back and let me talk about Glucotrol instead of glucophage, which is what I was talking about. Sorry, my things were out of whack. The screen is correct. The stuff that you are frantically writing down is correct, but what I'm saying is not quite what's on the screen. Now let's talk about what's on the screen. Okay, sorry about that. These are the second generation sulfonylureas. That was accurate. But what these drugs do, they stimulate insulin production. Okay. They also improve the action of insulin at the cellular level. No, just the glucotrol. The glucotrol XL, and Amaryl is another one. Amaryl. That's another one of the newer ones. So it decreases the glucose production by the liver, and it stimulates insulin production. Okay. These are, like I said, are your first line, and so these really work better if you can start them early in the disease. Now, they do have side effects. Anything that we're giving to decrease the blood sugar always carries a risk of hypoglycemia, so that goes with all of them. Okay, this can also cause weight gain, and you do have risk of drug interactions. If your patients are taking calcium channel blockers, remember a lot of these people will have congestive heart failure and cardiac issues too. Okay, if they're taking calcium channel blockers, steroids, Lasix, they can get into hyperglycemia. If they're taking these medicines and also taking heparin or antibiotics or beta blockers, they can get into hypoglycemia. Antibiotics and beta blockers. Heparin, antibiotics, and beta blockers with sulfonylureas can cause the patient to have hypoglycemia. Yep, hyperglycemia is if you take it with calcium channel blockers, steroids, and Lasix, or Lasix. So we really want to be careful using these with any kind of liver problems, renal problems, and the patient needs to take this medication before meals. Your Prandin and Starlix are two examples of maglitinide analogs. These are similar to the sulfonylureas in that they affect insulin production, stimulate insulin production, but these really work better when they on the meal released insulin secretion thing. So you want to take this one before meals, because that's where it's going to work. Remember I said when you eat, within 10 minutes you get a bolus of insulin secreted? That's what this works on. Okay? It increases that secretion, and it prevents the post-eating blood sugar increase. That way when they eat, their blood sugar doesn't shoot up to 250. Very rapid absorption, short duration. But we want our patients to omit this if they're not going to eat. And if they eat an extra meal, they usually are instructed to take an extra dose. Okay? Glucophage is your next one. The biguanides. I don't know where they come up with these names. This is the one I was talking about a minute ago. It decreases liver glucose production, but it doesn't work on the insulin secretion. The other two did. This one works on the production of glucose from the liver standpoint. It also helps to increase the usage of glucose by your muscle cells. So a lot of times what you'll see is you'll see patients on two medications. They may be taking glucophage and glucotrol at the same time. The glucotrol is increasing the insulin, the glucophage is decreasing the glucose production. So your patients may be taking both. Your patient does not usually have hypoglycemia if they take this one by itself, because it's not dropping the sugar. This one doesn't drop the sugar. But we have to be very careful because this can have some issues with the kidneys. So glucophage cannot be given if the patient has kidney disease or congestive heart failure. If your patient, bless you, if your patient is going to have any type of radiology where they're going to get contrast, IV contrast, you have to hold glucophage for 48 hours before and 48 hours after. Because it can get in, you can get into some lactic acidosis and that kind of thing from it. Okay, so glucophage, you got to hold it if contrast is going to be given. Right. Your alpha glucosidase inhibitors, glycet, acarbose, delay absorption of carbs from the small intestine. That's how they work. So they work at the GI level. So you're going to have GI consequences here. Gas, diarrhea, abdominal discomfort. We want to take these with meals. So your patient needs to take oral glucose tablets or gel to treat hypoglycemia. They need something that's going to work at the stomach level, because what they're taking a drug that delays carb absorption at the small intestine level. So you got to absorb it out of the stomach, not the intestine. Oh Lord, the TZDs, I can't say that word. I practiced last night and I never could get it right. Maybe why I have my shirt on wrong this morning. This is your Actose and your Avandia. These improve the insulin sensitivity in the body, and it reduces liver glucose production. So it improves sensitivity, so it works better at the cellular level, helps to reduce blood lipid levels, but these can have some pretty serious side effects. You can get into fluid retention, some congestive heart failure, and you can have liver damage from these medicines. So it's really important that we monitor liver function while your patient's on this medicine. We're not going to use this if the patient already has heart failure or if the patient is pregnant. And one of the biggest things with this is it can decrease the effectiveness of oral contraceptives. So a lot of them out there, a lot of different mechanisms of action, but the majority of them either stimulate insulin secretion or stimulate the sensitivity, or they decrease glucose production. Okay. Kind of how they work. All right. Let's talk about complications of diabetes. Complications come along from these changes in blood glucose levels, and the better we can keep it under control, the less chance that we have of some of these chronic problems. Now, they can be broken down into macrovascular, which means the big blood cells, the big blood vessels and the big blood systems, or it can be microvascular, which are the tiny microvascular veins, arteries, arterioles. Okay, so when we're talking about macrovascular, we're talking about cardiovascular disease, cerebrovascular disease, and peripheral vascular disease. Common complications, common comorbidities with diabetes. 65% of deaths from diabetes also have some aspect of these macrovascular complications. Okay. So the ADA recommends that we keep blood pressure below 130/80, that we keep cholesterol levels below 200, that your patient stops smoking. We want their A1C to be below 7. Below 200. We usually put these folks on an aspirin. And we may put them on an ACE inhibitor. Okay. Why do you think diabetes predisposes somebody to these complications? What is it related to? Blood and what? The breakdown of fat. The breakdown of fat stores. Okay, leading to atherosclerosis. Okay. Increased insulin can damage the lining of your arteries, the vessel lining. So atherosclerosis actually develops faster in your diabetic patient than it does in the non-diabetic. Cardiovascular problems is the most common of these. Women tend to have it a little more than the men do. No, cardiovascular complications. And the leading cause of death is a myocardial infarction. But keep in mind, your women don't have normal signs and symptoms of a heart attack. Your diabetics don't either. Okay, they do not have the typical signs and symptoms and may not have typical chest pain. So we've got to have aggressive management of their lipid levels, their blood pressure, and their blood sugar. Less than 130/80. That's our goal. Remember we talked the other day when we were talking about hypertension that we're shooting for below 140/90, but if they got diabetes, we want it less than 130/80. Okay. Your patients with atherosclerosis also have problems, big risk for stroke, And when your diabetics have a stroke, they are more likely to have a full-blown stroke than they are TIAs. Do you know the difference? TIAs are transient ischemic attacks where they have just some minor deficits, sudden onset, sudden resolve. It comes and it goes. Okay. A CVA or a cerebrovascular accident is a stroke that comes and stays. Okay, the deficit stays. That's usually a bleed, an infarct in the brain. A TIA is not. It is not usually a bleed. Peripheral vascular disease, y'all have talked about ad nauseum, I'm sure. That's lower extremities and feet. You know what that is. Okay, that's another reason that foot care is important. Okay, because they usually have peripheral vascular disease going on. So our treatment here: weight loss, exercise, stop smoking, getting good control of their blood pressure, good control of their cholesterol, and good control of their blood sugar. So your role is to monitor and try to prevent some of these complications. Now, when we're talking about microvascular, these are the little blood vessels. Remember when we were talking about complications from hypertension? And I said you get your damage from where the little arteries are? And we would revisit that when we talked about diabetes. Here we go. Because where are your smallest veins and arteries in your body? Your eyes, your kidneys, your feet. Right? So, when we're talking about retinopathy, that is where you have damaged capillaries in the eye that causes retinal hypoxia and small hemorrhages that eventually damage the retina. Your patient can have edema in the eye, and then they actually can get like fatty deposits in the eye. Your patient may complain of seeing spots. Their vision it's like they're looking through a cobweb, and it's usually a very sudden onset. There is a condition that's called proliferative diabetic retinopathy. This is where you actually grow new retinal blood vessels. But what happens, the ones that you regrow are very fragile and they bleed very easily, so you get hemorrhages in the eye. Proliferative diabetic retinopathy. So you've got retinal changes. Okay, your patient has changes to their vision. They may have if they've got a lot of edema in there, they lose their central vision. Okay, they can't see straight forward. Okay, they have good side vision. But usually with your changes in blood sugar, hyperglycemia, your patient complains that their vision is blurred. Hypoglycemia, they may see double. The patient is more prone to getting cataracts and glaucoma. I'll talk about those next semester. Okay. But with glaucoma, you have increased blood pressure in the eyes. So that's another reason that we don't want to be doing those exercises that causes that to go up even more. So these folks need to have annual eye exams. They may even be qualified for early laser therapy if they've got that macular edema that decreases their central vision. Okay? If you have a patient who's cold and clammy and suddenly a diabetic patient who's cold and clammy and they say, I see two of you, I bet you their blood sugar is low. Everyone I've ever seen that says that I see double, their blood sugar is low. Okay, your patient may experience nephropathy. Nephropathy is kidney damage, right? You see this in type 1 and type 2. But increased pressure in the small vessels of the kidney eventually damage the filtration process. You have loss of protein. And you may also have excessive kidney perfusion. Just trying to, that polyuria. Sugar in the urine and high blood pressure also work to destroy the glomeruli in the kidney. Remember that, the filtration part of the kidney? It destroys that. Reduced kidney function leads to kidney failure. That's why you see a lot of folks who have diabetes, they end up with dialysis. 30% of your patients will get end-stage renal disease. And this is a later complication. You usually see this in the folks who have had diabetes for about 10, 15 years. You don't suddenly get kidney failure from diabetes. It's a process. The earliest sign that you're having kidney compromise as a result of their diabetes is that they have protein in the urine. You're going to see high blood pressure. Your BUN and creatinine will be elevated. And you have decreased urine output when you have, when you have renal failure. So what have we got to do? We got to control their sugar, control their blood pressure. We need to treat any UTIs that they have. Okay. Keep them hydrated. We usually give them ACE inhibitors. And sometimes we may need to restrict the protein intake of the patient. Okay. So retinopathy, eyes, nephropathy, kidneys, and then neuropathy is progressive deterioration of the nerves. So your patient's going to have pain, loss of sensation, muscle weakness, and they usually complain of tingling, numbness, and burning. And what happens is eventually they get a complete loss of sensation in that area. And it can be anywhere. But the majority of what you see is in the feet. And it progresses from there. So safety and risk for injury is big with these people who have neuropathy. Yeah. But he never was, and he had been type 1 all of his life, and he never was compliant. So he was already getting dialysis, and he was 40. So, okay, we got to keep going. I'm sorry, boy, I did digress. Okay, so when we have neuropathy, safety is a big, big issue. Keep in mind, it may be a focal problem. It may affect only one nerve, or it may be diffuse, widespread. It usually affects both sides, not just one. Okay. All right, so macrovascular, we got the big vessels, the big systems, the heart, the circulatory system. Okay. Macrovascular, big ones, microvascular, small ones. Eyes, periphery, and your kidneys. Okay. All right. Questions about that? All right, let's talk about some complications and then we'll go. These are emergency complications that you may run into with your folks who are diabetic. There's 3 of them. The first one is hypoglycemia, acute hypoglycemia. This is when the blood sugar drops below 60. Now, I will tell you, some of your patients may not have any signs and symptoms at 60. Okay? It depends. I know you hate it. It depends on the patient. Okay? But we need to start being kind of concerned if our patient is getting around 60. Okay? Factors that cause hypoglycemia is, of course, insulin and your oral meds may drop it. If your patient's not getting enough calories, maybe they're exercising too much, burning off that sugar. Medications can be reacting, like we talked about with some of your oral meds. And then your alcohol intake. Remember I said they can have that rebound hypoglycemia. This is your most common acute complication with diabetes, is that the patient's blood sugar drops. And remember, it climbs slow, but it'll drop fast. Your patient may have symptoms at 70. So you're treating the patient, looking at the numbers. These are the signs and symptoms that you have. The first few are your most common. Your patient's hungry, they have a headache, they're nervous, they may have some palpitations, and they may have tremors. And then from those initial ones, it progresses to the rest of them. They may get pale. They may be sweaty. Tremors may get a little more pronounced. Then you start to have some of the central nervous system issues. Difficulty concentrating, confusion, slurred speech. Once your patient starts to have neuro symptoms, you've got to act very quickly because their blood sugar is so low at this point, their brain's not working correctly. Brain function is being compromised. Okay. When we reach the severe level, disoriented, loss of consciousness, unresponsive, seizures, respiratory rate gets shallow. Okay, a person cannot bring themselves back from this. They need intervention. Okay, once they get completely disoriented, they're not going to be able to treat themselves. So we want to instruct our patient, if they ever start to have the problems with, tremors, their vision is blurring, they need to act fast at that point, because they will deteriorate quickly from there. Okay? Keep in mind your patients that are on beta blockers may not have those early signs and symptoms of hypoglycemia. Okay. So what are we going to do? We're going to act. If our patient is conscious, we're going to give them 10 to 15 grams of a simple carb, something quick acting. Give them some orange juice. Make them chew up a piece of candy. Give them a Coke. Okay. Concentrated sweet liquids. These start to work in 1 or 2 minutes. Just a couple of minutes. Things like juice, 4 ounces of juice, 8 ounces of milk. You can give them some glucose tabs. My sister carries Lifesavers for Christopher. A tablespoon of sugar or honey will get that simple carb in. Okay? Act pretty quick. Check their blood sugar. If it's still low, we want to repeat that. Okay? But if it has come back up and your patient is feeling a little better, then we want to give them some regular foods, remember, to maintain that blood sugar. Fix them a sandwich. Give them some peanut butter and crackers. And you really want to repeat that every 15 to 30 minutes until their blood sugar gets at least above 70. Again, you're going to treat the level, not the patient at this point. That's probably about the only time you will ever hear those words. Okay. Any other time, I'm wanting you to assess the patient and treat the patient, not the number or not the monitor, but treat the patient. In this case, because people do react so differently at 60 versus 70 versus 30, you have to treat the number. Now, if your patient is unconscious, then they have to have usually an injection, either IM or sub-Q glucagon, or we may need to give them an IV push of D50W. It comes in a big old 50 milliliter syringe, and you just push it as fast as you can push it. You may, if your patient has an NG tube, you can pour them some Coke down the NG tube. Or you can put some of that glucose that's kind of like the gel stuff, you can put that under their tongue or right at their gum. So conscious, we're going to give them something by mouth, recheck it every 15 to 30 until we get to 70, and then longer acting carbs after that. If they're unconscious, we're going to give them, in the healthcare setting, we're usually giving them an amp of D50. But at home, your diabetic will probably have one of those pens that they can just give themselves a shot, or somebody can give them a shot quickly, okay, of glucagon. So hypoglycemia. Most common thing you'll see. Now, two more we need to talk about. One of them is called diabetic ketoacidosis, or DKA. Sometimes this is how we diagnose diabetes, because your patient comes to the hospital unresponsive and a blood sugar of 800. And so we get to looking, and that's what they have, is ketoacidosis. This is a progressive hyperglycemia. The blood sugar is usually above 300, but because they have a lack of insulin, they're breaking down fats and proteins, and they get into an acidotic state. Okay, they still have, when you get to check, if they're unresponsive, when you get to check-in, they've had the 3 Ps, they've had weight loss, anorexia, nausea, vomiting, headache, weakness, dehydration. These people may even be in shock if they're that severely dehydrated. Now, who's going to get this? Type 1s or type 2s? Type 1s. Type 1s get ketoacidosis because they don't have insulin. Okay? They get into electrolyte imbalances, hyperkalemia. It goes from the intracellular fluid, it goes to the outside extracellular fluid, so your potassium levels are up. And then your patient progresses to a metabolic acidosis. And the way that they try to compensate for that is by trying to blow off that extra carbon dioxide and the extra acid. So they start to have what we call Kussmaul's respirations. These respirations are very deep and very rapid. These are not shallow puffs. Okay? The most common cause of somebody developing ketoacidosis is because they've got an infection that shoots their blood sugar up. Sometimes stressors or another illness can do that. So it's from not enough insulin, maybe too much exercise, because that can throw you into an acidotic state as well. Okay. And some medications. Any kind of meds that are going to increase the blood sugar can cause that. All right, so diabetic ketoacidosis. What we do for it is we try to get that blood sugar under control. We're going to give these folks a bolus of regular insulin IV. And then we may start them on a insulin drip. We want to bring their blood sugar down slowly. We don't want to just suddenly drop it to 40. Okay? So we're going to give them a bolus, and then we may hang a drip so that we can slowly bring the blood sugar down to normal. So we're going to be doing a lot of finger sticks on these folks. Sometimes as much as every 30 minutes. Our goal here, like I said, is to drop it slowly. You want to bring it down about 75 to 150 an hour, if you can. And again, they're acidotic, so they're going to keep their drip until their bicarb level comes down to normal. We've got to manage their fluid and electrolytes. We're going to put these people, get an IV going. We're going to give them a fluid bolus, probably about 1,000 cc's as fast as it'll go in. You're going to drop about a liter, over about a half an hour, maybe to an hour. Get them hydrated. And then you're going to drop it down. You're going to start normal saline, but then you may go to like a half normal saline. Then maybe D5.5 once your blood sugar gets around 250. Remember, we may have potassium deficit in the cells, but once we get our patient hydrated and the blood sugar becomes more stabilized, that may self-correct itself. So you have hyperkalemia when it moves out of the cell. You have that at first, but when you treat it with fluids and you give the patient fluids and insulin, you flush that out and some goes back into the cell. So you just have to recheck that level to see, do you need to treat the potassium level. If you do, you're just going to give them potassium riders, IV, to up their potassium level again. Right. Got to manage their acidosis. Watch for EKG changes. Rapid reversal of the acidosis can alter your patient's mental status. So this is a process. Anything metabolic, you don't need to just suddenly switch on and off. Okay? You got to try to get that blood sugar under control and then monitor to see what else you need to fix. Questions about DKA? DKA are the folks that come in that are a lot of times lethargic. It's like they're drunk. And sometimes that is the initial diagnosis until they get lab work back and they see that elevated blood sugar. Okay. These are the people who have the fruity breath I was telling you about. Okay, because their blood sugar's so high, they're breaking down fat, they're blowing off that acid, and they have that sweet smelling breath. Now, DKA type 1s, type 2s tend to have this hyperglycemic, hyperosmolar state. This is very similar to DKA, but there is no ketoacidosis. Okay. What happens is their blood sugar is much higher, usually above 600. And as a result of that sustained diuresis from their blood sugar being so high, they start to have the signs and symptoms, the neurologic problems, and hyperglycemic signs. Okay. This is a slow occurring phenomenon. It's not like overnight. Remember, it goes up slow. Okay. This usually is in your older adults. So their blood sugar is rising. They're continuing to have insulin secreted to prevent the ketosis. So that's why they don't have the ketoacidosis. But it's not enough to prevent the blood sugar from spiking up that high. Your patient may have lost 15 to 25% of their body fluid by the time they present. They do have severe dehydration. This may be from infection, some type of illness, any meds that cause the blood sugar to rise, or sometimes therapeutic procedures like dialysis or surgery can cause it. So treatment in this case, what do you think the treatment is? Fluid therapy, absolutely, and then control of the blood sugar. Right. Your goal is to rehydrate your patient and restore their glucose within 36 to 72 hours. So with our fluid, we've got to increase that blood volume, so we're hanging normal saline. And we're infusing it about 1,000 milliliters over an hour. And then we're going to hang it at 1 to 200 milliliters an hour. What you got to watch for? Fluid overload. Watch for respiratory compromise. Watch for cerebral edema. Those kind of things. So we've got the IV going. Now we've got to look at the insulin. But we're going to do that once the fluid has been replaced. We'll bolus them with some insulin, and then we may need a drip too. So do the fluid first, then we'll treat the hyperglycemia. It may take 3 to 5 days before your patient shows improvement in their neurological signs. A slow process. So with both of these, they have hyperglycemia, they have fluid loss, okay, but you don't have the acidosis in this one like you do in the DKA. Right. Questions about that? Okay. After the test, okay. Yes, ma'am. Got it? Okay. One other thing I want you to be aware of is diabetic children. Have y'all talked about diabetes in 106? Doing that today? Y'all can say, we got this. Y'all can just tell Miss Scott or Miss Lawless, we got this. Okay. I won't get you started. I'm sorry. All right. Keep in mind with diabetic children, you still have the classic signs and symptoms of diabetes. What are they? The 3 P's, right. There you go. It may be noticed first because of bedwetting. Okay. These kids may have an issue with bedwetting because of the increased urine output. Or maybe a bedwetting that you can't get the kid over and get corrected. Your diabetic children can be and need to be responsible for their care once they reach, that age. And that age is going to differ from child to child. Okay? But they need to know as well what's going on with them. Education, they actually have diabetic camps that are like week-long or weekend-long camps that everybody in the family go to. It's fabulous. They go and everybody learns about diabetes. Even the siblings have their program that they take at the camp. Grandparents go? Because who did the kids stay with a lot of times? They stayed with their grandparents. I think I was the only one in my family that my sister didn't take to diabetic camp. Kind of missed out. Because apparently it was fun. They had a great time. I guess she figures on you. I don't know. So education, you gotta do that with the kids, parents, and everybody. Okay. Keep in mind, it is difficult to control the blood glucose in the kids during growth spurts. Okay. What do you think it does? It goes up. Okay. It goes up. The kids can participate in sports. You just have to watch them. You have to check their sugar. And a lot of times your children are on sliding scale. Children are mostly what? Type 1s or type 2s? Usually type 1s, right. So they need insulin therapy. So Christopher plays football, and he uses the pump, but he can't use that with football because it gets hit and knocked. So he treats his before with sliding scale before he goes for a game. So it can be done. You just have to work it. Diabetic children need to be under the care of an endocrinologist. Okay. That may not be everybody's opinion, but that's my opinion. And please keep in mind, these kids are going to rebel worse than they already do. Well, it has bigger consequences here, you know. So if their friends are going for the Mountain Dews and the Sun Drops and the Snickers bars, that's what they want too. And of course, my sister's like, oh no, Christopher would never do that. I'm just waiting. I'm waiting. Because Christopher is now 16. Here it comes. Here it comes. So they are going to. So you just have to be prepared and talk to them about, you know, things that they can do. Because it is not, you know, bread and water anymore. They can, you know, they can have a life. Okay. Parents are usually very, very involved in the diabetic care for their children. So keep that in mind. Once the child ages, you're still going to gear more toward the child, but you're still talking to mom and dad too. Really, kids should be able to administer their insulin themselves by the time they get to be 9. That's kind of our goal. So the earlier it's diagnosed, the easier transition that you have. But sometimes it's not noted until your patient is an adolescent. That's tough. That's tough. So in children, you may need to give insulin in the arms and the legs, or in the behind, until their abdomen is more fully developed. Their abdominal muscles are more fully developed. But as far as the hypoglycemia, the DKA, all that business, children have that risk as well. So the quicker we can get that under control, the less chance of organ damage and complications that we have with those folks, okay? Okay, I'm done. Any questions on any of that? Not yet.